Welcome. This is our second to the last lunch and learn for the semester. So we've had a very exciting set of seminars. Today I'm going to be presenting on suicide risk assessment. And so I kind of jammed a ton of information into these slides. So I'm going to try to go through it. Hoping to get through all of this, but it's such an important topic. I was like, what can I take out? I was like, no, I really can't. So we'll do our best to get through. But if you have questions, anything that you feel free to interrupt me in anything. Okay, so I don't have a clicker, so I'm going to try to on here. Okay, so what are we going to talk about today? We're going to talk about briefly just about suicide in West Virginia, and talk a little bit about suicide risk screening, as well as the risk factors and warning signs related to suicide risk. I'm going to talk, spend most of the time talking about suicide risk assessment techniques and things, tools you can use to, once you have a concern of the risk for suicide, how you can do assessments to see how acute their risk is, and then we're going to talk a little bit about safety after planning for who are identified as hazard. I also have some handouts as well when I talk about suicide risk, and give you guys specific tools. These are all available, freely available online as well. So I'll show you. Let me figure out how to do this without looking at the thing. So maybe I'll just stand back here. So first of all, some background information, just some brief stats. So West Virginia, why do we care about suicide in West Virginia? West Virginia has currently the 11th highest suicide rate in the US. And actually, since I first did a similar presentation, I was updating the stats, we've actually moved up, not in a good way. So we used to be the 12th highest, now we're the 11th highest. Suicide rate in West Virginia is 5% higher than the national average. And on average, a person dies from suicide approximately every 24 hours. The other thing I want to just point out is there's a lot of kind of talking literature that, you know, we also know that we have a huge opioid problem in West Virginia, huge opioid overdose death rate. And there's some conjecture that about 20 to 30% of opioid overdose deaths might actually be suicide. So this rate might even be higher than what we have. So let's talk a little bit about screening first. So there are two types of screening protocols. So there's what we call universal suicide risk screening, which means that we screen everyone in a particular population or agency for suicide risk. So for example, an example of that might be universal suicide risk screening in primary care. So perhaps all the primary care patients that come in get a brief screen for suicide risk. There's also what we call targeted suicide risk screening, which is based on risk factors, warning signs, suicidal gestures, or thoughts. So in other words, there's some sort of concern at, that somebody presents, and so you screen them for suicide risk. So I'm going to talk a little bit about some specific suicide risk screening tools. So one of the things that's really important whenever you're doing particularly universal suicide risk screening is to make sure you're using what we call validated tools. So these are tools that have been tested in the literature and found to be valid and reliable. And basically, I mean, that makes sense, right? But a lot of times when people screen for suicide risk, they tend to use questions that have not been validated. And so, you know, the question is, how valid are you? So these are three that have been pretty widely tested in the literature. The first one that I'm handing out now is called the Ask Suicide Questions, or the ASQ tool. And this is part of a larger toolkit, which is put together by NIH. It has 4 to 5 brief suicide risk screening questions. Basically, that if the individual gets 4 yes or no questions, the answer yes and no, then they're considered at risk until they get the fifth, what we call the acuity question. Are you having any suicide right now? And so anybody who says yes to that fifth question is considered to be acute risk, at acute risk, and probably need an immediate crisis referral and possibly hospitalization. People who answer yes to the first 4 but no to the fifth are what we call non-acute. And so those folks would benefit from a further suicide risk assessment. You know, how immediate the risk is not a factor. Go into it more about that. The other one that's used a lot, which I'm passing around because it's used a lot, but it's also not my favorite suicide risk screening tool. It's the patient health questionnaire. So this is actually a questionnaire that was designed for to screen for depression. And so most of the items ask about depression, but there is one last item that you'll see when we pass around that asks specifically about suicide. So, so the last question item 9 says, ask people to rate how much they have thoughts that they would be better off dead or hurting themselves. Anybody off the top of your head have any ideas about what might be problematic about that question? Yeah.
Supposed to ask them that are going to make it go for time. If we had hurting themselves, but we can't do that for yourself, not hurting yourself, but that's not.
Right. So that phrase is really vague, right? Hurting yourself could be, we don't know about time, first of all, like you said, but also it could mean anything, right? It could mean making superficial cuts. It could be really big. So it's not asking directly about suicide. So this is, again, a lot of places, particularly primary care, use this as a suicide risk screen, but it's not the most valid. So if I were promoting a particular universal suicide risk screen, I probably would. That's my personal bias. Take with it. The other one that is out there, which has been pretty well validated, is called the Columbia Suicide Severity Rating Scale. And this one is a really, a nice screen. The tricky thing with the CFSRS is that it's very long and it's very detailed. So a lot of times it's not as practical for places that need to do brief screens like medical settings, hospital settings. But it is a very good tool. So I'm not going to go into that in a lot of depth, but it's around. So these are all freely available. Like I said, and we will post this PowerPoint on the website, State Social's website. So these are some nice. So some things to remember about screening suicide risk. First of all, like I said, using validated measures increases the likelihood of identifying risk with minimum of false positives. You don't want the problem with the PHQ-9 item is that you get a ton of false positives. A lot of people saying yes, but they're not really suicide, right? And it also has been shown to fix people who are. The other thing is that when you're doing risk screening, you should always have a policy or protocol for follow-up care for patients who are identified as at risk. There's no good to just give the screen to a population of patients and then have no protocol to follow up, right? And it's also important to be aware of local resources. So again, you need to know who you can refer folks to, who are the crisis resources in your area, what impacts the access to all of these. Lots of settings. So I'm going to talk a little bit about some general risk factors. Before I do that, have questions about this?
Sample policies for for follow-up care, or does the social work have them?
So actually, what I'm going to show you guys in a little bit is what's called the Brief Suicide Safety Assessment, which is a part of the ASQ toolkit that was put together that is actually a guide for suicide risk assessment and follow-up. So I think that will, I'm going to go over that when I talk about risk assessment. Does that answer your question?
Yeah, sure. Thank you.
Yeah. Yeah. Well, so yes, if they're at risk. If they're negative, not usually reason to share. However, if you do a suicide risk screen with a teenager and they're positive for suicide risk, then you always want to share that with them and include them as part of the safety assessment. which I'll talk about. No, because you don't need consent because it's a safety concern. But you should always talk to the adolescent and explain to them, or usually adolescents, but it could be a younger child as well. Explain to them why to share their family member. And that's why important consent is important. And when you first start doing this, explain the parameters. So, in general, risk factors. So, in terms of sort of things we want to think about, if you're thinking about who you might be concerned about, or you might want to target for screening. Some of the demographic groups that we know are at higher risk are Asian white males, who are adolescents, American Indian, Alaska Native, individuals that relate high suicide rates, LGBTQ, and no, stand back here, Michael. Other risk factors, we know that depression is associated with suicide risk, substance use disorder, particularly alcohol, but also opiates, like I mentioned. Non-suicidal self-injury, so that involves injury that's not suicidal in nature, but things like cutting or burning, things like that. Bipolar disorder and schizophrenia has a high comorbidity with suicide and PTSD. So you can see that if you're just screening for depression, you're not going to necessarily catch everybody. So that's the other thing that happens. A lot of times folks will screen for depression. If somebody's not depressed, they don't ask about suicide risk. So we know that there are a lot of diagnoses where people can be at risk and not necessarily have depression. Other risk factors, a previous suicide attempt, any family history of suicide, past trauma or current trauma, chronic pain is another risk factor, traumatic brain injury, as well. Recent losses, humiliation, shame, or despair. That includes things like bullying for teens. And environmental, so isolation, lack of social support, and then what we call suicide contagion. So any of you have heard of like schools where like one teenager might die from suicide and then there are like 3 more suicides the next year, right? So that's an example of suicide contagion. So caveat about risk factors. So the most important aspect that determines acute risk is their current level of suicidality. So that means, do they have the means, do they have intent, and do they have a plan? So we don't need to hospitalize every 50-year-old white male who has passed SI just because they are one of those risk factor groups. And I used to do a lot of emergency room work, and there was a medical doctor in the ER who was famous for any time somebody who was in one of those risk factor groups and said something about suicide, he wanted to immediately hospitalize them, even if they had no plan, no intent, or whatever. So these are things to consider, but the most important thing in terms of acuity is their means, intent, and plan. I'll talk more about that in a minute. So some acute risk factors and warning signs. So these are things that like are more kind of immediate. So anytime somebody makes a statement about suicide or engages in any kind of self-harm behavior, obviously. Anxiety and insomnia are often a warning sign. So has anybody here, talking to the backs of your heads, I apologize, but has anybody up here ever not been able to sleep, or if you've had young children not been able to sleep because they're up all night? Yeah. Did you feel like psychotic when you didn't have enough sleep? Yeah. So, you know, when I had my son and he was sleeping like an hour each night, I could like understand why people could seriously lose it. So if you're predisposed to being depressed or anxious or whatever, and you know you're not thinking so straight, it's not a huge true. Increased alcohol or drug use. So these are big ones. Anytime somebody talks about feeling hopeless or feeling like they're a burden to others, or they seem like they're withdrawing socially, or they feel trapped, those are signs that somebody's going to be at risk. Rage or acting recklessly. Somebody's going out and getting into bar fights every night, or they're driving 30 miles over the speed limit. They're driving while intoxicated. That sort of, again, if it's different from their baseline behavior. Some people do this stuff all the time. It has something to do with being suicidal, but it's something you want to think about. And then dramatic mood swings. Talk the world one day, and then they're completely depressed. Next thing in terms of risk factors I'm going to talk about is This is Thomas Joyner's Interpersonal Theory of Suicide. Has anybody heard of this? No? You have? Okay. So Thomas Joyner is a really well-known suicide researcher at the University of Florida. Believe it, it's one of the Florida schools. I'm sure if that's the right one. But anyway, he came up with this theory basically that there are sort of 3 factors that lead to somebody being at acute risk for lethal or near lethal suicide attempts. One of these circles is what we call thwarted belongingness. So that sort of that feeling like I'm alone, I don't fit in. You know, I don't have a group or a cope. And then there's this perceived burdensomeness. I'm a burden to others. Everybody would be better off if I just wasn't here, right? Has anybody ever heard somebody suicidal say things like this, right? And then there's this third. So when those things go together, they sort of people can have what we call desire for suicide, so this desire to end their lives. And then the third circle, capability for suicide, really involves, you know, being able to actually cross that threshold between thinking about it and actually doing something to your body. There's a lot of things that can contribute to this. So one of the reasons, you know, drug and alcohol use often leads to this is that if you're injecting yourself with needles every day, you probably can't cross that threshold of already having time. Same thing with non-suicidal self-injury. You're beating your wrists or your thighs or whatever. Cross that threshold. If you've had a previous suicide attempt, you've already done, so you have that acquired capability. But the reason veterans are in such a thing is they've had horrible things happen to them. They may also have done horrible things. A lot of violence. So what Joyner said was that, you know, when all these 3 things come together, that's when people are at risk of what we call lethal or near. Anytime you are talking with somebody and you hear all these 3 things, that's probably any other questions? So what do you do? How do you assess suicide? How do you assess suicide risk? So I like to show this card, safety, suicide assessment 5-step evaluation and triage. This is a nice guideline, kind of identifying risk factors. When you're doing a suicide risk assessment, you want to identify risk factors, you want to identify protective factors, conduct your suicide inquiry, and then determine risk level intervention. So that's sort of a nice how you want to do that. So the other thing I'm going to pass out, what I mentioned before, this is the ASQ Brief Suicide Safety Assessment. And this is a really nice kind of 2-page guideline for how to conduct a suicide risk assessment for somebody. This is if somebody either screens positive to one of those screening questionnaires or has said something to you that makes you think they might be at risk, or there's just something up where you're concerned about safety. So, and what I've kind of done is I've modeled what I'm going to talk about in terms of suicide risk assessment based on this. So the one that I just handed out to you is the child and adolescent version. There is also an adult version, and it's online at the website that's right there. The main difference is that the child version has a section that includes talking to the parent, right? And the adult version doesn't. And then some of the questions are slightly different. Like in the child version, they ask about school. In the adult version, they ask about work. So the first thing you want to do is praise and thank the patient for disclosing information. Why is this important? Why might we want to praise the patient for lying? I feel like they're doing the right thing. Yeah. It's something we personal. There's also a huge amount of stigma around suicide, right? So people are often very ashamed. I think particularly in rural West Virginia, stigma and shame around mental health and stuff. So, you know, you want to thank them and acknowledge that there are hard things to talk about, but then it's on the ask the questions. The other thing this does is it builds rapport.
question, and they'll report what they find is around.
What to ask about? So the first thing you want to ask about is suicidal ideation, plans, and behaviors. So past and current, right? So it's best to ask direct questions and, you know, like, tell me about what thoughts you're having. How long have you had these thoughts? You know, have you ever tried to kill yourself? Have you ever tried to end your life? And again, it's good to be concrete and specific and not use vague questions like, have you had thoughts of hurting yourself before? Again, that's really vague. Plans, you know, if you were going to kill yourself, how would you do it? And you can get really specific about that, right? So like, they tell you, well, you know, I jump off a bridge. Which bridge? How would you get there? You know, what do you imagine would happen if you did that? I'm going to overdose on pills. What pills? Where are they? How would you get access to them? This gives you a sense of kind of how well thought out the plan is, and also like, do they have access to the means? If somebody tells you, I'm going to overdose on pills, but I don't know which pills, and I don't have any in the house, I don't have any, you know, the plans to go out and get them, you're going to be less concerned than somebody who says, yeah, my mom's bottle of Oxy is in the cabinet, I'm going to go home and take, and I know it's full because I checked this morning. I'm going to go home. It's the bottle. And you also want to ask about past behaviors. You know, you want to ask about rehearsing. Like, have you done anything to practice, right? Somebody says they're going to hang themselves, you know, have you practiced this at all? Do you know how you would do it? And they say, well, you know, I practiced tying the noose and I've hung it from my, you know, closet bar, and I'm not ready to try it out yet, but I might try it out. And that's called rehearsing. You know, we're going to be more concerned about somebody that says that as opposed to somebody that says, I don't really have any clue how we would make a noose. It's just something that I thought about. Risk factors, you want to ask about all those things that I just talked about: mood and anxiety, isolation, irritability, substance use, sleep and appetite, social stressors, and then protective factors. So we'll go through this in more detail in a minute. So again, suicidal ideation, you know, so I talked about this a little bit, but, you know, in the past, ask about frequency, duration, and intensity. How often have you been thinking about killing yourself in the past few weeks? Are you having any thoughts of killing yourself right now? Another question you can ask is the scaling question. How intense are these thoughts on the scale of 1? Right? Are you thinking about them all day long? I talked about this a little bit already. Plan and needs. Do you have a plan? How would you do it? Where? When? With what? Etc. And if they say no, you can also ask, if you were going to do it, how would you do it? That gives you a sense of how much they thought or something. And like I said, a detailed plan is more concerning than a more vague one. The other thing you could want to know about is intent. So like, what would you think ending your life would accomplish, right? So what is their, you know, everybody would feel better off if I was gone, or my pain would end. It gives you a sense of their motivation. Talk about rehearsal. How likely are you to carry out your plan? What stops you? This is a really important question because it gets at those protective factors. So if they say, well, you know, I would never do it because I think of my kids, right? Or my family. I mean, that's a huge protective factor. I'm going to be much less worried about somebody that says, I'm so worried about my family and what would happen to them, as opposed to somebody who says, you know, or even a pet, right? Sometimes a pet can be a factor, right? Or somebody who says, you know, I don't think, you know, anybody would care if I just ended my life. Because it gets at that belongingness and isolation. Religion can be a big one too. I've heard people say, I'm afraid I'll go to hell. Okay, you know, that stops you. That's good. Other risk factors. These are questions that are drawn right from that suicide safety assessment. Depression. In the past few weeks, have you felt so sad or depressed that it makes it hard to do the things you would like to do? You know, again, anxiety, impulsivity. Impulsivity is a big one. Why would we be concerned about impulsivity with suicide? Any ideas? Yeah.
Because when you're impulsive, you can just do it without thinking about it, as opposed to if you're thinking it out, you might talk yourself out of doing it.
Exactly. And that's one of the big reasons why adolescents have such a high suicide rate, because they don't think about it, they just do it, right? So, exactly. Excellent point. Yeah. And they don't, and adolescents view themselves as kind of invincible and they're not thinking about the future. Yeah, exactly. Hopelessness, again, that's another risk factor. Have you felt hopeless, like things would never get better? Anhedonia. How many of you guys know what anhedonia is? So anhedonia is basically not being able to experience any kind of pleasure, right? And so sometimes that can look like, this is a good question to assess that. People who have anhedonia, they may have things that they used to love to do. Maybe they used to love to knit or watch movies or listen to music, and they tell you, it just doesn't feel good to me anymore. Nothing I do makes me feel good. So that's another risk factor. Isolation, again, even keeping to yourself more than usual. Irritability, substance and alcohol use. Sleep patterns. So again, this is a good way to ask about trouble falling asleep or waking up in the middle of the night, different things that can interrupt sleep. Appetite. I know I'm going through these kind of quickly, but support network. This is a good question for adolescents. Do you have a trusted adult you can talk to? Because it may not be a parent, but as long as they have somebody that they can go to, they're more likely to disclose that they're having suicidal thoughts. It's one of the big protective factors. For adults, you can say, you know, kind of just switch the wording. You have a person you trust that you school or work functioning. Again, if you, as a result of this, you learn that they are just doing much worse at school or work than they have in the past, or all of a sudden they're just not showing up for work, they're not showing up for school, or they're not doing what they need to do, and that can be a risk factor too. Bullying for teens is a big one. Suicide contagion. You can ask about that by asking, do they know anyone that's killed themselves or tried to kill themselves? Reasons for living. This is a really good one to assess protective factors. What are some of the reasons you would not live? To just see, you know, protective factors. So other protective factors that I talked about, so sense of responsibility to family, social supports, life satisfaction, safe therapeutic supports, hope, big one. You know, some people said, you know, I've heard people say, I'm not going to end my life because somewhere deep down, I just have this hope that things will get better, right? And that's a really key factor. Religious faith or spirituality can be one. The other one is coping and problem solving skills. Somebody who doesn't have a lot of coping or problem solving skills, why might they be at more risk of suicide? They see no end, so they can't see kind of a way out. Yeah, absolutely. You know, this kind of adds more to those feelings of hopelessness, right? You know, so, but also, you know, if you have trouble, you know, suicide can be a way of dealing with a problem, right? So I knew a colleague once who would say suicide is a permanent solution to a temporary problem. Right? So it's a lot of times it's a way, if they don't have other problem solving skills, suicide might start to look attractive. Okay, before I move on to talking about adolescence, I know I'm going through this really quick. Any questions so far? Yeah.
So if you were like doing an assessment and you saw that they did have the protective factors, would you still, if they had a plan, they had all these things, would you like admit them and like still take it serious because they have all those things, or you know, not as serious because they have these things?
So I'm going to ask you to hold that thought. This is part of what I'm going to talk about next. Yes, excellent question. Couple quick things about working with adolescents. So when you're doing suicide risk screens with adolescents, you should conduct the interviews separately with youth and adults. Anybody have any idea why that might be the case? Yeah. Absolutely. All good reasons why. Basically, the ultimate thing that happens is you're not going to get a real sense of what's really going on with the adolescents. They're not going to see it. I found that it's usually helpful to meet with the adolescent first, you know, but sometimes that's not always, you know, possible. You also want to be aware of the limits of confidentiality and make them aware of it as well. If you're interviewing parents, I mean, it is good to meet with parents. I tend to meet with them separately at first, at least. You know, and these are some guidelines. Again, this is right from that safety assessment. You know, informing them that you have concerns about their child's safety, and praise their child for speaking up about the topic. That helps to take away some of that judgment and guilt around it. Ask to get their perspective. Try to find out if they've been aware of it, and then ask them about symptoms. A lot of times parents can give you information about symptoms that the kid can't verbally, right? So you get a fuller picture that way. These are just some other questions you can ask parents. One of the big things to ask parents about is this question, how are potentially dangerous things for them? Because research has shown that one of the biggest sort of ways to prevent suicide attempts and suicide and death is by means restriction, right? So means restriction means restricting access to things that people can use to end their lives. So for teens, you know, making sure that the parents know what pills are lethal. For example, so I was using the example of Tylenol and Advil. If you take a bottle of Advil for an overdose, you won't have an upset stomach, hopefully, but it's not. You take a bottle of Tylenol, liver failure. A lot of parents don't know the difference, right? So you know, and educating them, if they say, yeah, we keep all Tylenol but not Advil, so get rid of the Tylenol, get some Advil instead, right? Or lock up, you know, your pain prescription. Peloton, is it locked up? You know, can you get access to it? Or, you know, for adults, you know, Peloton. That could be a bonus. Yeah.
Can a teenager not go into like Walmart and buy a bottle of Tylenol though, or is that illegal? You can't do that in the shop.
Well, so they can.
Okay.
But you know, again, it's not perfect. But you know, obviously, one way to say, let's get all the pills locked up in there.
I was just wondering.
Make sure they don't put the top so that the CVS by themselves. But even just informing parents about this, you know, are you comfortable keeping your child safe at home with a sense of like how protective, you know, what that gives you a sense of like follow. You know, they don't feel like they can keep their child safe at home. And if you're meeting with the parent and the child together, is there anything else? Sometimes there are things that parents will tell you. So this is kind of, it gets back to Taylor's question. So you've asked all these questions. Now what do you do with these, right? And how do you know what to do? So this is a table that a colleague of mine put together, which I really like. It's a nice sort of cheat sheet for how do we determine risk level, and then what do we do depending on risk level. So there's essentially 3 levels of risk whenever you assess. Low risk, moderate risk. Somebody who's at low risk, they might have lots of debt, but they have no planned intention to pay. So perhaps they have lots of, you know, they say, I just want to kill myself. They maybe don't have a plan, don't have any idea how to do it, or they tell you, I just have just a thought pops up. we call passive. They also may have some risk factors, but perhaps they're not viable, or they have strong protective factors. Support network, family, religious. Somebody who's in this category typically is going to benefit from an outpatient referral, symptom reduction, and so, at the very least, you can give them those on the sheet. There's the suicide hotline as well as the text line, which is 24/7. We also have local crisis hotline. Right? You might also do a safety plan, which I'm going to talk about. Or like if they're, and you might do a public schedule follow-up. So maybe have reviews, maybe follow-up, CDL follow-up, some sort of follow-up. They don't necessarily need them. Somebody who's in the moderate category, they may have suicidal ideation with a plan. So maybe they say, I thought about taking, about, but I don't plan to do it. They haven't done it with person or anything. Maybe this person has a lot of risk factors. Isolated. Somebody you're worried about, like if things get worse, I worry about them. These people are kind of the toughest categories. Sometimes admission to an inpatient unit is necessary for the risk factors. Sometimes not. In any case, they should have some kind of a crisis plan and a follow-up. So, this is when doing a thing. But this is somebody who want to have high risk, somebody who might have, they have potentially either they made a suicide attempt or they have really strong ideation, they've reversed, maybe they have a strong plan. This is somebody that is like, and in addition, they've got maybe some other diagnoses, symptoms, something awful just happened to them, perhaps. Maybe their wife left them, lost a job, she died. Maybe this is sort of what we find. Like this is somebody who so these are, again, this is sort of what I talked about, but these are kind of the follow-up interventions. So somebody who's at high level of risk is at the very minimum going to need an emergency room referral and or psychiatric admission, a mental hygiene condition. So in West Virginia, I'm less familiar with West Virginia statute, but you need to file what we call mental hygiene condition to be admitted with voluntary. So the ideal thing is that somebody say somebody needs to go inpatient, and they say, okay, I'll sign this up. Sometimes you have people, however, that are adamant they don't go. Now, Massachusetts, we could just have a doctor and now social.
Yeah, I used to work on behavior. Yes, if you have an RE where anybody can file on it, okay. If there's that one in there, saying the sheriff will go out, the county commissioner will go out, so bring them to whatever emergency room first. But on our unit, they would move them straight to our unit. And typically by the next morning, they would have their with them.
I should add to that too. Obviously in an emergency, this stuff matters less. But unless things have changed over the last couple of years, they may have. This can also be a pretty traumatic process for people
Oh,
to go
yeah,
through
it is.
in all kinds of ways, not the least of which is because, at least when I was doing that kind of work, the standing policy of local law enforcement was to make sure that folks were in shackles, that they were picked up in a police car, sometimes in front of their neighbors, who then had questions about what was happening. None of this is a reason, of course, not to engage in the mental hygiene process if someone is at high risk. But it is important to remember that the process itself carries with it some really painful externalities for some of our clients, and so we have to be aware of.
That's a really good point, and it's why kind of doing such a detailed assessment is so important. You don't want to dig through that unless you're absolutely sure there.
I don't want to share chapels on places we probably don't buy their name. So, when I was so, because we talked about and then like kind of explain it in an illustrated way for them, so they know that there's something wrong at the same time. And they're like, I think they were somebody to share about the child and exactly so they're like, you know, people who automatically think they're in trouble. They're kind of like having that compassion, that concern, don't kind of elevate the like the situation. But you know, the officers aren't trained at the same level that we are as clinicians.
I don't know if they have it, but I know there was a move in some areas for law enforcement personnel, and not just for suicide, but also other, actually might be.
The legislature should be chatting on the issue that there are other ways for them, like first responder medical first aid,
Yeah.
the local street programs that happen. At least three ways of the department happens from the time we can choose this that would responses, which is really
So my sister had to do this for my mother, and we were talking about like how traumatic it can be. So my mother's a really violent person, so they go in, it's a whole thing, and neighbors and all this stuff. And in my county, I don't know how it is anywhere else, but in my county they take you to the facility or whatever it is, but they can only keep you for 72 hours. And so in her case, it made it worse. Not only was she violent with herself, but that opened it up for others. So when she gets out, everybody is like, so it kind of makes you wonder, in people like that, is it worth it? Maybe someone more compliant, it is. I don't think her case, I don't.
I think there's a lot of debate about kind of the utility of some of these forced admissions, right? And like, what are they actually doing for 2 hours? I mean, I think the argument for it is that at least they're safe again. And I have heard stories of people voluntarily hospitalized, and said later, I really needed that, so I didn't have
For the mental hygiene petition, does that have to be done through a court hearing, or can they like go wake up a judge in the middle of the night and have them sign for it?
I think it has to be a court. We're not in your head with that.
Yeah, and again, every county does it differently. In Marion County, mental hygiene commissioner, psychologist that's on that committee, they would come to our meeting. We were one of the, I think maybe the only county that they actually brought folks to us and they got to spend the night with them. Other places they keep it in jail. So it's different.
And it's not almost guaranteed. So, and again, these policies are very
moderate amount of use, take advantage of all the phone calls. It's come up with a new intervention called caring contact, where they will actually send text or an email or okay. But, yeah. Yeah.
The mind, like, yeah, that's what we're asking. So it wasn't doing.
So I actually have the mind free up here that I just
so let's talk a little bit about safety planning. So, which is part of what those have to do. So safety planning is basically, I'm going to just say that it's not the same as what all have suicide contact. There used to be this idea in suicide treatment that you should, if somebody was in suicide risk, you should have them sign a contract saying, I will not kill myself, if you sign it, then you can let me go. And what they found is that A, these are not effective, and B, they don't prevent you from being, anything legalized. So there's really no reason to. However, you'd be surprised. We'll use this writing. Safety plan, on the other hand, is usually involves identifying risk factors, protective factors, coping skills, and really giving clients a plan of what to do to manage their symptoms, as well as giving them who to contact at very level. So I'm going to show you this in a little more detail. So first of all, this involves helping patients identify warning signs and coping strategies. So a part of any safety plan, and there's a safety plan template, which if I don't have it here, I'll pull it up for you, that I use, or I have used with patients. First you identify, what are the 3 things that make you know that you're headed towards a crisis, right? So, and that's going to be individual for each person, right? So they may say, I'm sleeping more, or I'm starting to drink again, or I'm isolated. This is going to be an individual sort of warning sign that the patient can recognize and say, oh, I'm headed down a bad path. This might lead to me having more serious suicidal thoughts or actions. Right? And then you also talk about coping strategies. So what can you do to manage those feelings? So that can be different for different people. So like the first step of a safety plan is, okay, what can you internally do? What are 3 things you can do that will help you cope if you're feeling distressed or overwhelmed or whatever those things are? So that might be, listening to music. I had one adolescent client that loved to draw. Can you draw? Do some art, or, listen to a funny YouTube video, things like that. And then the other step of it includes identifying what are the social supports they can access. Who are their immediate people they can talk to, and it usually has a space for a phone number. A friend, it could be an adult, it could be a therapist, and so it includes different levels of people. We also, safety planning also involves needs restrictions, so that's what I talked to you about before. So, get rid of the gun, get rid of the pills, whatever. And then providing resources like those crisis text lines or hotlines, local and international. I'll talk about this. So these are contents of a sample safety plan, and that's what I was just talking about. So warning signs, internal coping strategies, people to contact or settings that provide distraction, people to ask for help, professionals and agencies, making the environment safe, and reasons for living. Right? And so this is done on a piece of paper collaboratively with the client, right? So it's a therapeutic process. You sit with them and you fill this out with them. And they can have it and access it. And there are also, so this is an example of the My3 app that Kia was just talking about. So this is an old screenshot, so it may have been updated since then, but again, it has their safety plan and resources on it. So you know, this is really good for adolescents. Well, actually, all of us. I mean, how many of us are like attached to our smartphone? I know I am, unnaturally so, as it's clicking off right now. But you know, this is a really nice way to have it at your fingertips, right? So that a teenager is less likely to lose their phone than that piece of paper that you give them, right? Same with other people, adults too. But there is also, I don't have it on here, but there's, if you Google safety plan template, there's a family round plan template that's really available online. There are other apps as well. So we have 2 minutes left. Questions? Any questions or anything that I didn't cover that you?
I know that this is all applied to suicide, but can this be utilized for maybe homicide as well, like homicidal thoughts in the patient? Or is that kind of a different?
This is a good question. So I'm not, I think that the safety issues are a little bit different. So with homicide, you have what we call duty of warrant. So you know that if somebody's at risk for themselves, or something else, somebody tells you they're going to hurt themselves, you have a legal statute. Called duty of warrant. You have reasonable information from the information that you have to warn that works on somebody. It's a little bit, it's less ethical in a weird way. It's kind of less ethical to send somebody to a safety plan to not kill other people.
Right. Well, I was just thinking because it's not, I guess it's not technically illegal until you actually commit the crime. So, I mean, I don't know what you can do if they're just thinking it.
I think you really have the duty of law. I mean, again, it's a safety assessment. If somebody is vague, and they tell you, I thought about telling my boss, but I would never do it. Also may want to get other factors.
And I think this is also where it's really important that you check and make sure whatever agency you work for has like a very well written policy about this kind of stuff. And if they don't, then be a good social worker and annoy them until they write it, right? And it's just like you need to have some guidance in those situations. But I wanted to ask if you could say something particularly for young clinicians about the affective side of this. So it's one thing to have a list of questions to sort of run through, either to screen or to help someone's safety plan. But how do you do it in such a way that balances the need to avoid conveying alarm on one hand, with the need to be warm and empathetic on the other? So when you're asking these questions like, how would you commit suicide if you plan to do it, what are some tips you could offer as far as your own affective presentation?
Really good question. So I think the first thing is you need to be aware of your comfort level with your topic. So a lot of clinicians tend to shy away and being vague. They're uncomfortable. We know that those vague questions are but at the same time, it's a sensitive topic. So, one thing, that piece of praising people and acknowledging this is really, I know it's really difficult stuff to talk about. I'm really glad that you felt confident enough to share something with me. Is it okay if I ask questions? All of those skills we use with other topics that are difficult to ask them. Because this is just another difficult topic, right? So we as social workers, we have to ask about child abuse, we have to ask about but again, that is still direct and to be straightforward with folks and maybe it's just because I've done it a lot. But when I ask questions, I did a lot of suicide risk assessments in our clinician. And I think the more that you show that you're comfortable asking questions, the more comfortable your clients are, right? So if you look anxious or if you look like, I'm not sure I should ask this question, they're going to be like, I'm not sure I should answer this question. So that's really important. Just making sure that you're comfortable with it, and that you
I knew this client wanted, for the most beginning class, this separation strategy. Even if like, instead of much being in there, and then like being very, very much into it. I mean, I've had times, I've had to say, I'm glad to see space to like, so then I have to gather them. Because it's not just about how, other things, you need to be very heavy, to be aware of how much you're able to keep in the information. You know, we're not superheroes, we're not one week, we're not going to fly. You're moving to, you know, some people I know that I work with have had things, they're not in a place where they can even fix something or anything like that, but they're able to admit that. It's okay. Don't try to do it.
The other thing is to remember that you should bring in a vacuum. It should always be patient. No matter how serious you are, you know, I would sit after doing this. As of today, but you know, I would still call my private patient. It's really difficult thing. There's a lot of nuance to it. There are a lot of times where you need to, and that's okay. That the mistake is saying, I don't know what to do with this person, but let me make sure I can figure it out. You know, just consultation, but I can be aware of like. Let me ask you, did I answer your question about the policy follow-up?
Yeah, I mean, it sounds like just consulting this toolkit is the best answer, but I do think, you know, finding sustainable policies online is hard, especially if they're inconsistent. Yeah.
We are just about out of time, so if you guys, if you haven't had time to complete the evaluation, you can do that and bring it up here, and sign a sheet wherever that ended up, and thank you guys all for coming. And, we'll be posting the PowerPoint on our election learning website.